So this is a patient who has come for an implant removal of the clavicle, young adult male, ASA grade 1, and the plan is to give him a interscalene block only with a peripheral nerve stimulator. We are not going to use the USG in this patient. We are going to do only with the peripheral nerve stimulator. I am going to use the HNS 12, the Stimuplex HNS 12. So if you see, that is the knob, that is the switch on button, and when you rotate the dial clockwise, you will set the required milliamp. Now we will set the milliamp up to 2. Okay, now we have set the milliamp at 2, and now the positive electrode is attached to the ECG electrode, and we are going to use a 50 millimeters. We are going to use a 50 millimeters insulated Stimuplex needle. This is the negative electrode. The negative electrode will get connected to the Stimuplex 50 millimeter gets attached to the negative electrode. The black color that you see is the negative electrode. So now the circuit is complete. The negative electrode, and here you see the positive electrode which is attached to the ECG electrode here. So now we are all set to go and give the block. But before you give the block, it's always good to fill the entire, you see the extension port through which you inject. We have removed all the air from it. So now we are ready with the circuit part. Now the plan is to give the interscalene block. And how do we identify the interscalene groove? Step number 1, if you see this patient in supine position, and we have put a small pillow under both the scapulas are taken with that. I'm going to give a block on the right side. So I'm going to give a right interscalene block. So I'm going to stand. Can you visualize? I'm just standing to the right side of the patient at the edge of the table. Now I'm going to turn his head to the opposite side. So one of the clues that how much to turn, what is the ideal way to turn, how much to turn, the chin of the patient should correspond to the mid-clavicular line. The chin of the patient corresponds to the mid-clavicular line. That's sufficient enough to produce a good, the anatomical landmarks will be identified very nice. It's not overstretched. Now the next thing is, can you all visualize the sternal notch? The sternal notch here. This is the thyroid cartilage. And that's the cricoid. Now, if you want to make the sternocleidomastoid prominent, can you see the prominent sternocleidomastoid now?
Yes.
So this is the sternal head. This is the clavicular head. And can you see the external jugular vein?
Yes, yes, clear.
Are the audience able to see that?
Yes.
You can focus it. So we see the sternal head, the clavicular head, and the EJB, which is visible now. So now, what's the method to identify the interscalene groove? We'd start at the level of the cricoid. Track your fingers laterally. First, you cross the sternal head of sternocleidomastoid. Then you cross the clavicular head of the sternocleidomastoid. When you are in the lateral border of the clavicular head of the sternocleidomastoid, tell yourself that you need to go further 1 to 1.5 centimeter lateral. This is very, very important when one uses a peripheral nerve stimulator to avoid going into the triangle between the lateral head of sternocleidomastoid and the scalenus anticus muscle. So this I want all of you to keep in mind. When you reach the lateral border of the clavicular head of the sternocleidomastoid, tell yourself that you will go another 1 to 1.5 centimeter lateral. So I'm going to go 1.5 centimeter lateral, and I feel the triangle. Now, if you see, my thumb is at the apex of the interscalene groove, and by this movement of my thumb, I'm palpating both the belly of scalenus anticus and scalenus medius. Now, what I'm going to do is I'm going to stretch the skin here so that I make the skin very taut. Is that clear?
It's clear.
Okay, now I'm going to go at the apex of the interscalene groove. That would be the point of entry of my needle. Can you see? I have not pierced the skin still, but can you see the contractions?
Yes.
3 milliamp. Can you see the contraction? I have not pierced the skin still. Okay, now make it 2. Make it 2. So now that means I am in the right interscalene groove. I am just piercing it. Yeah. Can you see that? Come here. Yes. Come here. Slow up. Yeah. Can you see the contractions now?
Yes.
So now we are slowly coming down. 0.8, 0.7, 0.6. 0.8, yeah, come down. 0.7, 0.6, 0.5. So we have come down to 0.5. Can you appreciate the contractions?
Yes.
Okay, now aspirate, inject. So the moment 1 cc goes inside, the stimulation stopped, the evoked motor response stopped, and this is called as the Raj test, which indicates the tip of the needle is very close to the nerve. For every 3 ml that you inject, you will aspirate and inject to make sure that you are not intravascular. What is very important when you do this block is the desired evoked motor response when you use a PNS is you should have the contraction of pectoralis, deltoid, biceps, and triceps. If you get at least 2 of this 4, then you are sure that you are in the appropriate groove and you can inject the drug. This patient has to undergo an implant removal of the clavicle. If you can see, the implant is almost visible externally. Are you able to appreciate that?
Yes.
Okay. So now what supplementary block that I would give for this patient alone, along with an interscalene block, I would like to give a supraclavicular nerve block which would make it complete, because the cutaneous distribution over the clavicle is supplied by the supraclavicular nerves. To do that, I'm not going to use a stimulator. I'm going to use a 26 hypodermic needle to give a supraclavicular nerve block in this patient so that the whole surgery can be done only under the block. So, was it clear with the interscalene groove, appreciation of the interscalene groove and the block? Dr. Sajish?
Yes, sir, clear.
What do the audience say?
Any questions? Any clarification needed regarding this?
Now I will just show you how to do the it's called superficial cervical plexus or a supraclavicular nerve block. Can you focus here? So, can you see the lateral border of the sternocleidomastoid?
Yes.
And can you see the EJV?
Yes.
Can you see the EJV here?
Yes.
So, take a 26 hypodermic needle. So now, the point of entry of my needle is here is the EJV, and here is the lateral border of the sternocleidomastoid. So just at the place where the EJV crosses the sternocleidomastoid, just above that, the skin and subcutaneous tissue, that's all. Were you able to appreciate that?
Yes.
Is it visible? Dr. Sajish?
Yes, sir.
Okay. So at the lateral border of the sternocleidomastoid, just above the place where the EJB crossed the lateral border, skin and subcutaneous tissue with 26 hypodermic needle, I would infiltrate about 4 to 5 ml, and this would make it as the supraclavicular block. Okay, so I just want to add one additional point. Interscalene block is highly recommended for every procedure above the level of the mid part of the arm. The only point I would like to emphasize is, if you are going to do a proximal humerus or a shoulder procedure, one nerve that you need to block is the intercostobrachial nerve. If you see, this is the axillary fold, and this part, this cutaneous distribution is supplied by the intercostobrachial nerve. So when you choose interscalene block for a shoulder procedure, it also becomes important that you would have to infiltrate local anesthetic solution subcutaneously to block this zone of the cutaneous distribution, which is supplied by the intercostobrachial nerve, so that the block becomes perfect. So that is a demonstration of using a peripheral nerve stimulator to give an interscalene block. Any questions?
Any question from the audience?
Excuse me, sir, can you please show the tunneling? I mean, I know you cannot put a catheter now, but can you just with a needle show the tunneling of the catheter?
Actually, we have a catheter insertion in one of the cases which is going to come later.
Thank you.
So we would show you tunneling in that.
So another question is that if EJV is not visible,
Yeah.
then supraclavicular, how can we locate?
Yeah, if the EJV is not visible, the way to give supraclavicular is to take the midpoint in the sternocleidomastoid, the clavicular head, take the midpoint of that and inject about 5 to 6 ml.
From the mastoid to the
Yes, the entire length of the sternocleidomastoid, the clavicular head, take the midpoint of that muscle, and then you infiltrate about 5 to 6
lateral to
ml.
the midpoint.
Yeah. So does it answer the question?
Yes, sir.
Okay, just for 2 minutes, as an additional procedure in this patient, we are just going to scan and show you. All of you are aware of this TAP block, one of the most popular blocks which is coming up now. This patient is for a clavicle procedure only, but however, just to give you the benefit of scanning and showing you the sonoanatomy of a TAP block, we have Dr. Marudachalam, who will just take few minutes before we go to the next block. Actually is to be done by Dr. Sandeep Diwan, who will do an interscalene approach for a patient with ultrasound. So we thought that you have seen the PNS and the next you will see the ultrasound. But before we go for that, quickly we will show you the sonoanatomy of the TAP block. Over to Dr. Marudachalam. Mike, please.
Okay. Good afternoon. I'm Marudachalam. I'm just going to demonstrate. Yeah. So I'm just going to demonstrate to scan the abdomen for a TAP block, which is transverse abdominis plane block, which is usually used for any procedures like laparoscopic assisted cholecystectomy. You can use it for laparoscopic assisted hemicolectomies, right or left hemicolectomies. We can even use it for inguinal hernia surgeries or any perineal surgeries. And this block is very useful where you want to avoid an epidural insertion or it's a difficult epidural insertion. It's nice and easy. So again, coming back to the ergonomics, if you're doing a block on the right side, keep your machine on the left side, and if you're doing the opposite, you change it vice versa. And then check your orientation with your probe. You select the appropriate probe. Though in this patient, we are going to use a linear probe. In obese patients, you need to go for a curvilinear probe for deep insertion. So you start with the midline. Again, you can ideally you can give a block above, right at the screening here, just underneath the rib cage or just above the highest point of the iliac crest. But ideally, if you want to block all the segmental nerves supplying the abdomen from midline below, you can use a midline approach which will spread along the plane above and below. So we just start scanning with the mid abdomen. So you will see the different layers of the abdomen. So if you can appreciate that, that's a midline exactly, and that's the rectus muscle, which is a rounded muscle which is going to end towards laterally, and then you get the other anterior abdominal wall muscles. This gentleman is nice and thin. He's got a very thin anterior abdominal fat. Then you get the external oblique, internal oblique, and then you can appreciate now the transversalis coming in. And if you can you focus there on the peritoneum? You can even visualize the peritoneum and even the bowel movement there, which is nice and clear. And then the point of insertion of your needle will be.
Sorry to interrupt, Dr. Mardarchalam. Can you show those markings, points?
Yes.
With the marker, please?
Yeah. Okay. So that's a bowel which is contracting, yes. And the moving part is the peritoneal marking. Okay, bring it there. That's the moving part is the peritoneum. And this one is the internal oblique. Oh, sorry, the transversalis, internal oblique, external oblique, and the extraperitoneal fat and the subcutaneous tissue. So when you're going to insert the needle, you have to go in plane and get the line of insertion and the needle, you can see coming down right there, and to your layer between the transverse abdominis and the peritoneum. But you need not go further in, otherwise you're going to injure the bowel or other soft tissues and solid organs. So you need to be careful. So that's why you need to use in plane and watch the needle right from the beginning, right to the point of insertion. So once you reach that point, I'll just scan further down. So once you reach the point of insertion there and inject the local anesthetic, that will nicely open up the space between the transverse abdominis plane and the internal oblique. You can even scan to the opposite side, and then you can do bilaterally when you need. Thank you. If any questions?
Any question? The question is, how much volume do you use for
Yes.
your local anesthetic and what concentration?
Yes, I usually use 20 mL of 0.2% ropivacaine on either side, so it works about 40 mL of local anesthetic for post-op pain relief. This is only an adjunct. It is not a totally dependent pain relief, but if you want to use it for continuous pain relief, if you want to use a continuous pain relief post-operatively, then you can put catheters on either side, and then you can use it for block, for post-operatively instead of using an epidural.
Thank you.
And this is very much used in even for lower abdominal cesarean section patients and for post-op pain relief and patients had a general anesthetic. So this is a very good adjunct which will help you with the help of the zone anatomy.
They want to know how much, what level of, how many dermatomes are likely to get affected with this block?
Yeah, the most of the studies which has been done shows about 4 dermatomes above and 4 dermatomes below. So that's why you want to help with post-op pain relief for your inguinal hernia surgery. You can come further down and inject about 20 mils, and that will help with your lower abdominal dermatomes.
Is Dr. Bala there? Because there's a question for him as well.
Yes, Bala.
Dr.
Thank
Bala,
you.
Thank you, Dr. Marzar. There's a question regarding the sterility of for these procedures, because there have been varying techniques among the various performers. What's your opinion, Dr. Bala?
Yes, actually, for example, even what we used, everything has been prepared, the whole thing was sterile. And even the marker pen was a sterile marker pen that was used. And I think it's very important to keep the sterility on, and because though the percentage of infection is very, very less as of now, it's very important to have everything sterile.
Thank you, Dr. Bala. Dr. Sandeep is just waiting.
Sure,
Yes.
yes.
Waiting over there.
Yeah.
Thank you. Dr.
Thank
Sandeep,
you.
we are coming live to you. Dr. Sandeep, we are now live with you.
Yeah, okay, thank you so much. Dr. Sajesh, can you hear me?
Yeah.
Yeah, okay. So, he's a 7-year-old child weighing around 33 kgs, and a cubitus valgus osteotomy to be done on the left side. The ergonomics is such that I'm on the left side of the patient, and I have the machine right in front of me. This is a linear probe, which is 6 to 13 hertz, and it's already draped with the offsite, and we already jellied it with a sterile one. We already prepared the neck of the patient, and the neck is quite thick, and he's quite obese that way. And if I apply the probe now, or the ultrasound probe, you'll be able to see those structures over there. Can you see those structures?
Yeah.
Yeah, the one in the middle, those are the superior trunk, the middle trunk, and the inferior trunk. Now, if you see the interscalene groove, it keeps on moving when he takes deep respiration, and that is where exactly Bala had inserted his needle, and he had given the interscalene block via the PNS. The one on the left side of the screen is the middle scalene muscle, and one on the right side is the anteroscalene muscle. See how the trunks, they keep on moving, and that is the reason why you have to be very, very immobile when you're using the PNS technique. But when you're using the ultrasound needle, which may be echogenic or may not be echogenic at times, we'll see when you insert the needle, and the needle is going to come in plane. That is, the whole of the shaft of the needle as well as the tip of the needle is going to be visible. Can I? So he's already anesthetized under sevoflurane and a small dose of ketamine, and you can see the puncture point over there. You see the puncture point?
Yeah, it can be seen.
Yes. And then you can see the shaft of the needle. Can you see the shaft of the needle?
Yeah, it is.
That entirely is the shaft of the needle. So the shaft of the needle is now coming very, very close towards the interscalene area. It is in between the superior trunk and the middle trunk. Can you see that?
Yeah.
Okay, so now it has pierced the middle scalene muscle. Can you remove the arrow? Yeah. And I am now trying to ask him to inject a few ml of drugs after aspiration. You have to aspirate even if it is under ultrasound. You need to aspirate. Can you aspirate? Yeah. And you inject just few mLs of drug. Okay. Can you see how the trunks are now getting displaced?
Yeah, it is.
Okay. Few more mLs. And you have to inject in small aliquot. So that is near the superior trunk and the middle trunk. You can as well as go towards the superior trunk and inject few ml of drug here. It's literally like chasing the trunks in brachial block. It's just like chasing the trunks. Okay. And it all lateralizes the trunk. Just a minute. Okay. Yeah. So it's all surrounding the brachial plexus now. You can see the trunk over there, the superior trunk. That over there is the superior trunk. And this is the middle trunk, and that will be the inferior trunk. So what was an immobile needle technique has now become a mobile needle technique. Because you can take your needle right from the superior trunk, you can inject few ml of drug over here, and then you can come down and inject your drug over here in the at the level of the inferior trunk. So it becomes a whole brachial plexus block, and if you go down, You can see those superior, middle, and the inferior trunk very nicely surrounded by the local anesthetic. Can you appreciate that?
Yeah, I appreciate.
Yeah. So the whole of the brachial trunk plexus has been anesthetized now. With we have taken 0.5 ml per kg body weight of 1.5% xalocan and 0.33% bupivacaine, which is given separately. You can use xalocan and adrenaline as well, but I usually do not use it in my practice. So this is the superior trunk, what you have seen right in above. In the my needle is at the level of the inferior trunk. Can you see that? The superior trunk, and then the middle trunk,
Okay.
and then the inferior trunk. All they are surrounded by the local anesthetic, and then as you go down, it divides. You keep on giving your drug. And see, I'm at the supraclavicular level. Now the anesthesiologist was here a bit worried whether you need an ulnar nerve block. You may not need it because now the drug has almost gone to the supraclavicular area. So it may not be needed. The ulnar nerve block separately may not be needed. We can evaluate that later on during the perioperative period. So if the needle is exactly in the sheath, as I mentioned in the lecture, and the sheath is one which surrounds the brachial plexus. Can you see that? The whole of the brachial plexus, right from the superior trunk, the middle, the inferior, and then the divisions, and right up to the supraclavicular area, is all surrounded by the local anesthetic. And if you go above, see, this is the superior trunk. That is the needle over there. Now I am going to remove the needle because you have injected everything. I am going to remove the needle, and we are trying to trace. Can you see the root over there? This is the root.
Sandeep, before you remove the needle, you show one out of plane view.
This is Guru Prasad.
Yeah.
This is the root. Can you see the root of the brachial plexus? Then it disappears. See, it is popping out. And the needle is exactly at that root. You concentrate on this, it pops, it goes inside and it pops out. It goes inside, it pops out. So this has also been anesthetized, and as you go higher up, you will see several of those roots going in one by one. That's gone in one. The second one is going in. Can you see that? The second one going in. So up to the level of C4, almost everything is anesthetized from the level of C4 down to the level of C8 and T1. I am removing the needle now. And the in-plane technique is one where you come from above. That is what is routinely what you do. Yet you come from the above at the level of the interscalene groove, and then you insert your needle out of plane. What we showed was in plane, where you can see the shaft of the needle and the tip of the needle. But with the out of plane technique, you only see the tip of the needle. But the tip of the needle may not be necessarily the tip. It might be one of the shaft, because the shaft also appears as the tips at times. And you have to be very, very careful when you go out of plane technique. I usually go in plane all the time because it's quite easy to do. You see the shaft of the needle as well as the tip of the needle all the time.
Okay. Thank you.
Okay. Are you happy with this? That completes the block.
Yeah, Sandeep, will you show one more time how exactly you kept the probe on the neck?
Okay. We will now repeat. Can you remove this needle? Okay. Now, this is the neck of the patient. Can you just zoom out? This is the neck of the patient. Can you see the ear? It's turned on the opposite side. I have gave a small lift over here because it's quite obese, and I've asked one of the theatre attendants to pull the shoulder because he had a very short neck. So I asked her to pull the shoulder. When you keep the probe, you have to keep it at this point in the transverse. This is the transverse view. When you come down, it is the sagittal oblique in the supraclavicular area. While you go above, it becomes the transverse. So the in-plane technique is one where you get your needle in where you get a needle in plane. That is, it goes right across the probe in plane. So it goes in this way. So when you go in this way, you can see the shaft appearing. Then you can see the tip of the needle appearing. And whatever structures you want to target, you target in the center of this probe, so that it will be more easier for you when you get your shaft of the needle and the tip of the needle. So when you put in your needle skin and subacute, then you have to make a bit of the angle because they are quite superficial structure, the superior trunk and the middle trunk. You have to make a bit of the angle, and then you have to go very, very close to the probe. So this area has to be very much sterile because this is one which comes in contact with the tip of the needle. So need to be sterile. And as I showed you,
There was one more question, Sandeep.
1 minute. Let me finish, Guru. Let me finish with this. Now, see, can you see those trunks?
Yeah.
Okay, they are actually sandwiched between the middle scalene group of muscles, the middle scalene and the anterior scalene.
Right.
Okay, now as I probe downwards, you can see it immediately divides. Can you see the divisions?
Right. Right.
Okay, they are divided and now form a clump. They are not in a straight line like this.
Yeah.
They are form a clump. As you still go down, you can see they still more divide and redivide and again redivide, and they're all surrounded by local anesthetic. Okay.
Yeah.
Can you see the subclavian artery pulsating over there?
Yeah.
Very much down. It's being pointed out now.
Can you put it on color?
Yeah, color Doppler. We'll do it. We'll do that. Can you see that now? It's on color Doppler.
Okay.
And can you see the brachial plexus and how close it is to the subclavian artery and the pleura? It is just on the top of it.
Yeah.
Can you remove the color? Okay. So the whole thing is surrounded by the local anesthetic because it's now enhanced. The local anesthetic solution itself, it enhances, it acts like a contrast and it enhances the gray plex structures. And as you go above, you can see the local anesthetic, how it has surrounded the brachial plexus. You move above and you can see now the superior trunk is separated from the middle trunk. Can you see that?
Right.
The superior trunk is separated from the middle trunk, and then as you go above, you can see it goes inside, pops in, and there's another structure which pops in. So these are the roots which ultimately form the brachial plexus. One coming out, the second thing coming out, the third thing coming out, and then they form the brachial plexus. They form the subclavian perivascular and down into the subclavian area. Yeah, your question, Guru.
You blocked all the three trunks. Now they want to know how much volume did you use, total volume?
I told you it's around 0.5 ml per kg. He weighs 33 kg, so it's around 14 ml of drug. And this is 1.5% xalocan and 0.33% bupivacaine.
Okay, thank you. It was excellent demonstration.
Thank you so much, Guru. We are going to ahead with the second block. Somewhere else.
Any questions?
Dr. Sandeep?
Yes.
No, I mean, we are ready in the next room. You have something more to show, sir?
Yeah.
Thank you, sir.
Dr. Bhatt says you can go to the next theater.
Thank you, sir.
Meanwhile,
Dr.
any
Bala?
questions, please?
Dr. Johannan John.
Yeah, I'm here. I'm here.
Hello, sir. Good afternoon.
Good afternoon.
So next case is a very young girl who has come for an implant removal of the forearm. And in this patient, we are going to do a subclavian perivascular block with a peripheral nerve stimulator. So the identification of the interscalene groove is just almost similar to what we did in the last case. Can you just focus on that? So this is the head end of the patient. Here you see the head of the humerus and the shoulder. This is the sternal notch. I'm just lifting the head of the patient. Can you see can you focus
Yeah,
it?
we can see that. We can see that.
Yeah. So you see both the heads of the sternocleidomastoid, and at the level of the C6, 1.5 centimeter lateral to the clavicular head, what I'm identified is the interscalene groove. Can you focus on that? Yeah. Okay. So that's the apex of the groove. For a subclavian perivascular block, I need to go down on the groove to the base of the interscalene groove. So I'm palpating the 50 millimeters needle. So at the base of the interscalene groove, I'm palpating the pulsation of the subclavian artery. I just want you to appreciate the position which I use. I use my thumb to fix the subclavian artery.
Does that tally to about mid-clavicular line?
Yeah, actually, I really don't mark the mid-clavicular line. I identify the interscalene groove, and I go track down the interscalene groove to the base of the interscalene groove. At the base of the interscalene groove, I palpate the subclavian artery. My thumb is palpating the subclavian artery now. What we need to do is, you need to position your thumb in such a way that it's exactly situated at the base. If you see the triangle expands, in the anatomy you would have seen the triangle expands from the apex. As it go down, the base becomes broad. My finger is exactly occupying the entire base of the interscalene groove, and my thumb is palpating the subclavian artery in the whole of the base of the scalene groove. Now, the point of insertion of the needle, can you see I'm about to insert the needle. It's going to be at the middle of my thumb. Stimulation. I'm just going to go with roughly about, can you show me? Slow. 1.5. Okay. Yeah. So it's set with milliamps. Now, in the middle part of my thumb, can you see the contractions?
Yeah, we can see them.
Slow. Yeah, decrease the current. I pierced. Decrease. Decrease. If you see the HNS12, initially the current was displayed above. The moment you pierce the skin, it gets displayed down. Decrease. Yeah, show the contraction. Yeah, and this coming, the deltoid coming, inge coming. Can you see the deltoid contractions?
Yes, we can.
Can all of them appreciate that?
Maybe if they focus a little more on the deltoid.
The deltoid is in the shoulder coming.
Yeah, we can see that.
Yeah? Can you see that? Dr. Yoganand, can you appreciate?
Yeah, we can all see it.
Decrease. Yeah. At 0.5, can you see that?
Yeah, still going well.
Okay. Aspirate.
What is the exact direction of the needle?
I've gone posterolateral to the artery. So step number 1, identify the interscalene groove. Step number 2, go to the base of the interscalene groove, palpate the subclavian artery, fix the artery with I used my thumb to fix the artery. Then I inserted the needle. The point of entry is at the midpoint of my thumb, imagining that the tip of the needle will go posterolateral to the artery. Within half a centimeter, she's a very thin patient, within half a centimeter, you get the desired evoked motor response. It should be the distribution, the response, the evoked motor response should be involving the muscle groups of the distribution of the 4 nerves forming the brachial plexus. In this patient, we focused more on, you could see the excellent contraction of the deltoid. And in fact, I'm not sure whether you appreciated that we also had the stimulation of the posterior cord. So was that clear, Dr. Yogan and John?
It was very clear. What was the amount of local that you've been using?
So actually, I use always a mixture of lignocaine, adrenaline, and bupivacaine. And usually also to add 1 mic per kg of clonidine to this.
All right. And the volume?
Yeah. The volume is for a subclavian perivascular block, she's about 15 kgs. We used about 25 ml of the solution here.
Right. Thank you, Dr. Bala. I think that was a lovely demonstration.
Okay. Thank you very much, Dr. Yohannan. They already did. Yeah? Is there any questions in this particular block?
Yes, please. There's some more questions, sir. Sajesh here.
Yeah, because we'll take another 2-3 minutes for the next case to be ready. If there are any specific questions, I'll be willing to answer.
Hello, Bala sir. This is Dr. Vaibhavi here. I just wanted to ask you, would it be ideal to check the spread of the drug with the help of USG machine?
Yeah,
Is it
actually,
possible?
oh, 100% yes. You want to see now?
Yes.
Yeah, okay.
Thank you, sir.
Dr. Manikant has a question for you as well.
Yeah.
Now, do we need to check whether we still have muscular contraction at 0.2 millivolts before giving the drug?
Actually, there is a lot of different school of thoughts on this particular issue. Normally, I don't go down less than 0.4 to 0.5, and for the simple reason that with this current itself, the tip of the needle is very close to the nerve, and my fear is if I go down as low as 0.2, the chances of me injuring the nerve might become very high. So, and also because of the fact that if you get a good evoked motor response at 0.4 to 0.5, the block is perfectly good. So my fear is whether I will produce more of nerve injury if I go down. So I limit it to 0.4 to 0.5, and I feel that that's extremely good to get a good surgical analgesia.
No, I think you got my question wrong. We did not check whether we got a muscular contraction at 0.2 millivolts.
No, why do you?
Unless we check that if we had gone down there and we still had a muscular contraction.
Oh, you are saying that
Yes.
possibly whether it could be an
Yes.
intraneuronal.
Yes.
Yeah, one of the nice ways to, that was a good question, but the intraneural injection, it's the resistance that is offered when you inject the drug is very, very high, and also it produces a tingling and paresthesia sensation, but more importantly, it's very difficult to inject. If it's intraneuronal, the tip is intraneuronal, it's very, very difficult to inject and the resistance is very high. I feel that is a more important parameter rather than going down to 0.2. But of course, there are various ways of doing it. Some of them would like to go down to 0.2, check and then come back, but I normally don't do that. But the most important point I take into consideration is the resistance offered to injection and patient complaining of discomfort while injecting.
Yeah, when we have an assistant, like a theater assistant, who does not know exactly how easy the drug is flowing or what resistance it is flowing, then we can't rely on him totally unless you have another anesthetist along who really understands it. So
Yeah, true. I mean, true. That is, if you don't have an expert assistant with you, they will not be able to do this. But I also feel that when people are working in those situations, I think it's best they can inject the drug themselves. My only fear is, like when you try to go down to 0.2, the chances of injuries are still the chances of injury would be there. So you're trying to go very low down in the milliamps. Then you try to go pretty close to the nerve.
There's one more question for you, Bala.
So I am Dr. Ravikant Sharma from Amritsar. What is the ratio you use lignocaine and bupivacaine?
I use 50-50.
And what are the maximum doses in a single patient of each?
Basically, in the extremes of age, I'm very, very careful with the dosings. Like you don't cross the milligram per kg body weight of the dose. But in young fit adults, especially occasionally when you want to do some rescue blocks, then you can probably slightly go higher on the dose, basically because the rate of absorption of the drug from the periphery is much less compared to what it happens in the epidural or intercostal space. But then it's best to stick on to milligram per kg body weight, not to exceed the dose in all your patients.
Thank you, sir.
Dr. Balavenkat,
The next case.
I just wanted to ask you, in such a thin patient where you encounter the end motor response at maybe 1 or 2 millimeters from the skin, and suppose while injecting you get resistance, then what do you do? And you can't withdraw it furthermore, you'll be injecting subcutaneous. Then in such cases, what do you do?
Yeah. Actually, in fact, if you see, in this patient, I got it within half a centimeter.
Correct.
I got it within half a centimeter, and then the question what you're asking is...
Yeah, suppose if now while injecting, there is a lot of resistance.
Yeah.
So if the nerves are superficial, it might still be intraneural.
True, absolutely true. It could be
And
intraneuronal.
If you withdraw a little, then you will probably come out of the skin.
No. You see, actually, that means the distance between the skin and the neural tissue was so less. Yeah. And the whole concept of using a PNS or an ultrasound is just to place the local anesthetic solution close to the nerve. Right. So you could still inject. Okay. It will definitely work. No, until otherwise you're intraneuronal, you won't get the resistance. So, I mean, your question is sort of a predicament which you ask you are saying that in thin individuals, the chance of becoming intraneuronal is very high. Is that what you mean?
Yeah, he's coming back.
Yeah, okay. Okay, the next case is ready.
Probably the answer that you are expecting is, should Bala have reduced the milliamperes to 0.2 and see that the response is not there, and then come up again on the milliamps and see whether at 0.3 or 0.4 you get the twitches again? Correct. That is what you are asking?
No. My question is,
no, he's asking intraneuronal resistance.
Yeah, the nerve is so superficial that while injecting you get resistance.
No, Shailesh, I understand that, but why you should get a resistance here? I did not understand.
Because the nerve itself is so superficial.
Yeah,
that
I can understand that.
No,
it's not such a compact structure. There's such a connective tissue. They have non-neuronal as well as neuronal components. It's not like an interscalene area where it's very compact. So as you go from above downwards, the supraclavicular area is not so dense. Like it has got some connective tissue along with it. So unless and until you're in the interneuronal space, I don't think so. You should get any resistance. Did you get Shailesh?
No. What I was thinking is whether
I think
if
we'll
you're
go to the
in
next
the
block.
intraneuronal space.
So we'll go to the next block. We'll answer him later.
I think we'll answer you later, Shailesh.
Yeah, sure.
I think we can answer.
Thank you so much. Dr. Bala, would you like to continue with this in this room, or shall we shift to the
We can shift. Yeah, we can shift.
Sir, one small question, please.
Question to Dr. Bala, ma'am.
Sir, one question, please. Sir, why are we mixing two local anesthetics?
Dr. Bala, we are still with you, Dr. Bala. Dr. Bala, we are still with you.
Okay. The question is why you are using two local anesthetic solutions. The reason being the rate of onset with lignocaine adrenaline is much faster, and we always feel that when we mix both the drug, the rate of onset, since it's fast, you can continue with that, but since we use bupivacaine, the duration of the block could be lasting longer. That's the logic behind using both the drugs together.
So, sir, if it is only for post-operative analgesia,
you can just use
bupivacaine alone or bupivacaine alone?
Perfectly is fine. If it's not for surgical anesthesia, you can just use long-acting bupivacaine or ropivacaine.
And if it is bupivacaine alone, then do you add adrenaline to it anytime?
The drug that, I do not use that, and if it's bupivacaine alone, the drug that we use, the common adjuvant we use here is clonidine. 1 microgram per kg of clonidine is the one which I commonly use with all my blocks.
Dr. Bala, one more question from the audience. Your probe, your needle,
Stimiplex needle.
Yeah, was quite far away from the positive electrode.
Yeah.
Any reason for that? Is what they
No. It was. I don't know how did you gauge it, but it was pretty close. The distance probably between that needle and the positive electrode was about 4 centimeters maybe.
Bala, this is Dr. Mahajan from Nashik.
Yes.